Great. Thank you very much, and many thanks for the invitation from the committee to be here. I'm delighted to be here in such a prestigious setting. And I'm going to talk a bit about some of the different concepts underpinning multimorbidity, frailty, and disability. When Professor Valderas asked me to do this talk, I asked him how far he expected me to get in an integrated conceptual framework, and fortunately he said not very far. So that's good. So compared with the wonderful keynote talk we've just heard, my talk's going to be very simple and simplistic, and is really setting the scene for the future discussions today. So I'm going to talk a little bit about the concepts and definitions of multimorbidity, frailty, and disability, to raise some questions on possible approaches to an integrated framework, and to, most of all, encourage debate and discussion. So I don't think I need to spend any time saying why multimorbidity. It's an increasing problem in just about every country of the world, certainly in high-income countries, with more people developing multimorbidity as they age than having single conditions. This is work we published from Scotland, just mapping this out on about a third of the Scottish population, but it's the same in most developed countries and is becoming the norm elsewhere. We need to realize that multimorbidity is socially patterned. It's not equally distributed, and this is the same graph from that paper in the Lancet in 2012, showing the distribution of multimorbidity by deprivation. This is the most affluent 10% of the population in Scotland, and going down the deciles to the most deprived 10% in red. So as deprivation, where people live, this is based on postcode, as you live in poorer and poorer areas of Scotland, so you get more multimorbidity, and you get it at a much younger age, a 10 to 15-year gap in terms of onset. And of course, research interest in multimorbidity is rapidly growing. This is the number of publications on multimorbidity over the last 10, 20 years, and that's very good for us who research it, but of course it does mean that there's more answers to be found. And just very briefly, and again I don't think I need to point this out to this audience, but the terms comorbidity and multimorbidity are often used interchangeably, but strictly speaking, comorbidity is where you have an index condition, such as diabetes, and you're interested in people with diabetes who have other conditions. It's a term largely relevant to specialist practice or secondary care, whereas in primary care, we tend to have multiple conditions over the life course, and we tend not to focus on one problem, because what's an issue 1 month or 1 year may change the next. So we use the term multimorbidity, which doesn't imply any particular single disease being predominant. So what do we mean by multimorbidity? Well, most publications, including the UK NICE guidelines, simply defines multimorbidity as 2 or more long-term health conditions within an individual. And this can include physical and mental conditions, ongoing conditions such as learning disability, system complexes such as frailty or chronic pain, sensory impairments, and alcohol and substance misuse. And a more recent publication by the Academy of Medical Science in the UK has slightly extended this definition to include an infectious disease of long duration such as HIV and hepatitis C. And this is because this particular report takes a global focus, and in many countries such as sub-Saharan Africa, of course, HIV and hep C are enduring long-term problems. But within multimorbidity, there's many other definitions. There's always been debate as to whether it should only be chronic conditions. Some people in the original work included acute. Other commentators have included a more social definition. My colleague Graham Watt in Glasgow defined multimorbidity as the number, severity, and complexity of health and social problems within families. The European General Practice Research Network have a definition that includes chronic disease with acute or chronic or biopsychosocial or somatic. So there's many different definitions, and in fact there's well over 100 different terms being used in different research papers. There's also no gold standard way on how to measure multimorbidity. Most papers tend to use disease count, just a count of the different conditions, but we don't have an agreed list of which conditions should be included. The numbers vary widely, and we often don't include disease severity. And in terms of weighted scales where severity is built in, again, there's no particular gold standard. It really depends on the choice of outcome, what your research question is, as to which measure is most suitable. And it's also usually influenced by the data that you have available. So it's often much easier to simply count multimorbidity than to have a weighted scale. So frailty. Well, I'm a general practitioner, not a gerontologist, so I'm probably one of the least qualified people in this room to talk about frailty. But briefly, this is a commonly used definition, a clinically recognizable state of increased vulnerability resulting from aging-associated decline in reserve and function across multiple physiologic systems, such that the ability to cope with everyday or acute stresses is compromised. And in terms of models of frailty, there's two predominant types in the literature. One's the phenotype model by Freed et al., where frailty is defined on the basis of having 3 or more of a set of criteria. And I won't go through these, but things such as unintentional weight loss, walking speed, and so on and so forth. The other model is the cumulative deficit model of frailty index, and this, again, is quite widely used. Originally included a very large number of deficits from structured clinical examination, but in principle these can vary between studies and populations. It's said that the index remains valid. There's no standard list of deficits that you have to include, but there must be ones of increasing prevalence with age and be associated with poor health, and not to be too rare or too common. Generally it's said that there should be 30 to 40 of these that are added up and divided to give an index between 0 and 1. Again, there's no gold standard as far as I'm aware, but the phenotype model is by far the most widely used in epidemiological research. But in clinical settings, of course, it's quite different, and often things such as the comprehensive geriatric assessment method is used by geriatricians, although it's very seldom used in primary care, certainly in the UK. And there's lots of other tools, questionnaires, single measures, grip strength, and so on and so forth. So disability. And here it's a bit different, I think, in context, because we had a model of disability, certainly in my early years. I remember as a young medical student, the move between these two models. The first one's the medical model, which simply says disabilities are a result of disease or impairment, and the person is disabled or handicapped, which was the old-fashioned term that used to be used. And around the 60s and 70s and 80s, disabled people themselves began to challenge this, and they argued for a social model of disability, saying that, okay, sure, we have some physical impairment, but we're also disabled by the attitudes of society, by the fact that buildings are not accessible, but because there's no lifts, and so on and so forth. So this was a political move, and quite a powerful one. And that makes disability a bit different, I think, from the discourse on multimorbidity and frailty, which so far hasn't reached this type of level of politicization, although it may in the future. So disability is defined under Article 1 of the UN Convention on Human Rights of Persons with Disabilities, saying that people who have long-term physical, mental, intellectual, or sensory impairments interact with various barriers which may hinder full and effective participation in society on an equal basis with others. And that's a very important human rights statement. And flowing on from that is the International Classification of Functioning, Disability and Health, the ICF framework of the WHO, which is the most widely known measure. And this was endorsed by all WHO member states in 2001. And the ICF framework is essentially a compromise or an integration of the medical model and the social model. And within the framework, it's, so I get my pointer, a person that can have a health condition, disease or disorder which may affect bodily function, leading to an impairment. It may limit activities. Participation can be restricted, and it's influenced both by environmental and personal factors. So this is where, for example, someone in a wheelchair may have a functional impairment due to a road traffic accident, but the participation restriction may be all to do with the social sides of access, employment, and so on and so forth. And in terms of measurement, the WHO Disability Assessment Schedule operationalizes this definition. There's a 36-item form and there's a 12-item short form. And this, the HUDAS, covers 6 domains: cognition, mobility, self-care, getting along, interacting with other people, life activities, domestic responsibilities, and so on, and participation. So again, you can see how this tries to embrace that integrated model of the medical and the social. But in practice, in clinical practice, there's many, many other measures in use, many clinical assessment methods used in different age groups and in different diseases. So, towards an integrated conceptual framework, well, it's not an easy task. I asked myself, why would we want one? If it's possible, is it desirable, and why? Is it for population approaches, epidemiology? Is it for health and social care planning, for service delivery and quality of care? Is it for research into intervention development, or simply so we can be person-centered? And I wondered also if multimobility, frailty, and disability are simply weasel words, which are defined as statements that are intentionally ambiguous or misleading. I don't think they're intentionally ambiguous or misleading, but there's certainly some confusion trying to make sense of all of this. So, what's the differences and what's the similarities? Multimobility versus frailty, this is a systematic review published this year, which looked at 48 studies and a large number of participants comparing multimobility with frailty. And in individuals who are frail, multimobility was present in 72% of cases with fairly wide confidence intervals. But the prevalence of frailty amongst multimorbid individuals is much lower, 16%. So they're not one and the same thing by any means. And I have a question. The first question is, should we focus on complexity as the way forward? Complexity is a concept which transcends all of these 3 terms, multimobility, frailty, and disability, and could be helpful in trying to develop an integrated conceptual framework. And work by Schenk and colleagues from Toronto kind of points us in this direction. They looked at patient complexity in a systematic review and came up with a unifying framework, the 5 dimensions framework, which has health and social experience at the top, medical, physical health, multimobility down here, the demographics of age and gender and so on, mental health, social capital, and it's all wrapped within the social, political, and physical environment. And I think aspects of the 3 things I've tried to define chime with this framework to some extent. Is a focus on health across the life course the way forward? Or the keynote speaker clearly pointed out this made sense. The WHO thinks it makes sense. The World Report on Aging and Health, published in 2015, takes a life course approach. And healthy aging defined in this as the process of developing and maintaining functional ability that enables well-being in older age. Functional ability comprising health-related attributes that enable people to do what they have reason to value, made up of intrinsic capacity and environment. So again, this combination of factors in the internal and external worlds of people. And if you look at intrinsic capacity by age, then again, as I think our keynote speaker showed, there's no obvious, this is males, females, there's no obvious point across the life course where things suddenly get worse. These are gradual trajectories, and there's very big variation by age. But it's important not to lose sight of the fact that socioeconomic status is important in all of this at every age group. So this shows physical functioning across the life course, age here, stratified by ability to manage on current income, the green being impossible to manage and the red being easy to manage. So a proxy really for the poorer people and the better off people. And at every point in the life course, this is important, but particularly in the middle age group. So finally, this is my second last slide. How do we make sense of this in terms of healthcare planning, deciding on research and priorities and so on and so forth? And another model put forward by the USA, the National Academy of Medicine last year, around effective care of high needs patients, have suggested this conceptual model of as a starter taxonomy, as they've called it. And in this, they take a population segmentation approach to the problem, with children with complex needs, non-elderly disabled, multiple chronic conditions, major complex chronic, frail elderly, and advancing illness, palliative care, and end-of-life care. And throughout this runs the behavioural and health factors and the social risk factors. So again, this is another way of looking at it. My slight concern with this segmentation approach, which is becoming very common, is we have to be very careful that these segments don't disassociate and become silos, so that care is siloed in these groups. It needs to be continuous across the spectrum, because I think that's good health care and good social care, but it's also likely to be much more cost effective if we have generalists working across the life course, such as general practitioners and others, as opposed to having siloed care with specialist and super specialist care. It needs to be integrated, otherwise it's not going to be cost effective or indeed the best care. So to summarize, multimorbidity, frailty, disability, three related concepts, not the same thing. The definitions and measures differ. There's few, if any, gold standards. And a focus on complexity may help unite these concepts into a framework that encompasses the wider aspects such as patient experience, environment, socioeconomic status, and social capital. And a life course approach such as that proposed by the WHO may help in understanding these trajectories and the key transitions for developing interventions. Thank you very much.